Hello everyone, in this video we are going to discuss about coarctation of aorta. So coarctation of aorta is a congenital narrowing or stenosis of a part of aorta. So what is aorta? It is a large artery that carries the oxygen rich blood from the heart to the body, that is from the left ventricle to the whole body. So here there is a narrowing at the of the aorta, that is called as a coarctation of aorta. This narrowing almost occurs always just after the origin of left subclavian artery, that is distal to the origin of left subclavian artery. So let us see the origins of different arteries. So in aorta there is ascending aorta, arch of aorta and the descending aorta. In the arch of aorta there is a brachiocephalic trunk which gives rise to right subclavian and also right common carotid. Right common carotid again divides into right external carotid and the right internal carotid artery. Coming to the left common carotid and the left subclavian, these arise directly from the arch of aorta, not like the right subclavian and the right common carotid which arises from the brachiocephalic trunk. So there is a part called as aortic isthmus between the left subclavian artery and the descending aorta called as aortic isthmus. So this is a part where there is a narrowing. So the narrowing occurs distal to the origin of left subclavian, typically at the level of ductus arteriosus. So what is this ductus arteriosus? In just it is nothing but it is there before the birth to shunt the blood from before it reaches the lungs, because lungs are not functional in the before birth. So it shunts the blood from the pulmonary artery to the aorta. So there is right to left shunt in the babies, in the children. To maintain the circulation, because lungs are not functional before birth. So this ductus arteriosus eventually will become the ligamentum arteriosum after the birth. So there is a aortic isthmus, as I already told, between the left subclavian and the descending thoracic aorta, where the narrowing will generally occur. There are two types of these types of coarctation of aorta, that is preductal and the postductal. So preductal means narrowing occurs before the ductus arteriosus. Postductal means after the ligamentum arteriosum, that is the ductus arteriosus will become the ligamentum arteriosum, that is that. So preductal narrowing occurs before ductus arteriosus, associated with severe narrowing and patent ductus arteriosus, more common in infants. So in the first picture is showing preductal type. Here we can see a black thing is showing the ductus arteriosus. So here ductus arteriosus is generally shunting the blood from the pulmonary artery to the descending aorta. So there is coarctation, that is stenosis of the aorta before the ductus arteriosus. So we know the head and neck part is better supplied, because there good supply is there because of the subclavian artery and the common carotid artery, they receive good amount of blood. But the descending aorta, there is, before reaching the descending aorta, there is coarctation, narrowing. So descending part, that is the descending aorta will supply the lower limbs and the lower part of the body. So the lower part of the body is not receiving good amount of blood. So in order to maintain the blood levels, there will be patency of this ductus arteriosus. Even after the birth, the child will maintain the patent ductus arteriosus in order to maintain this lower body supply. So there will be patent ductus arteriosus in preductal type, and it is more common in infants. Second type is postductal, also called as adult type. Here there is narrowing occurs after the ligamentum arteriosum. So it occurs after closure of the ductus arteriosus, which becomes a ligamentum arteriosum. So this circulation, that is right to left shunt, which is maintaining this blood supply to the lower body, is not there. That's why they have to develop another circulation called as collateral circulation through the intercostal arteries. So because of this collateral circulation, it is often asymptomatic until adolescence or adulthood. So the collateral circulation is through enlarged intercostal arteries, internal thoracic or mammary arteries, or scapular arteries. And so there is a thing called as rib notching on X-ray. We can see that is due to enlarged intercostal arteries eroding the ribs. So there is enlarged intercostal arteries which are seen in postductal type, that is seen at the inferior border of the ribs. Because of this repeated pulsations, these erode the rib, causing inferior rib notching, as we can see in this picture showing the arrows. Next thing is there is also called as which is 3 sign, which I will discuss later. So the clinical significance, we will see the clinical signs we here see are there is high BP in the arms and the low blood pressure in the legs. This is because the upper part of the body is receiving the blood from the aorta, arch of aorta and the ascending aorta, whereas the descending aorta is the where there is a coarctation. That's why there is less amount of blood received in the legs. So there will be low blood pressure in the legs, high blood pressure in the arms. So differential blood pressure, it is a clinical point. Second thing is weak femoral pulses. This is also because of the low circulation in the lower part of the body. Heart murmurs from turbulent flow near the narrowing. Because of this near the narrowing, there is turbulent flow is there. Because of that, we will hear the heart murmur. And there is rib notching on the chest X-ray because of the erosion due to pulsation from the intercostal arteries, which run inferior to the inferior border which run on the inferior border of the rib. Next is figure 3 sign on imaging, that is indentation of the aorta. So what happens is, this one we will generally see in aortogram or in the barium swallow. There is a figure of 3 sign. So the upper part is proximal dilatation, the central part, the notch, is the coarctation segment, and the lower part is a post-stenotic dilated segment. So this is the figure of 3 sign. So one thing we have to remember is to differentiate, how to differentiate between the preductal and the postductal. So preductal is infantile, postductal is adult. Preductal is before the ductus arteriosus, postductal is after the ligamentum arteriosum. Age of presentation is preductal, infants or neonates, postductal, children, adolescents or adults. Ductus arteriosus role is very significant in preductal because it is still patent to perfuse the lower body because it is infantile, but it is not needed in postductal because it is already closed and it is converted into ligamentum arteriosum. So there is no role of ductus arteriosus in postductal. It is severe in preductal type and is life threatening, but is often mild and chronic in postductal because there is collateral circulation. Whereas cyanosis is seen in lower body, cyanosis is seen in preductal type, and it is rare in postductal because of the collateral circulation. The collaterals are not developed in preductal because there is patent ductus arteriosus, but it is well developed in postductal type because of the collateral circulations, that is through the intercostal arteries and also scapular arteries and also internal thoracic mammillary arteries. Next is femoral pulses are weak or absent in preductal type, but is weak or delayed compared to the upper lip in postductal type. So the radiological signs are different here. Because of the collateral circulations in postductal type, we have already seen there is rib notching and figure of 3 sign. Rib notching is because of this collateral circulation which are eroding the ribs, intercostal arteries. So intercostal arteries will erode the ribs because of this pulsation. There is rib notching and figure of 3 sign. But in preductal type, there is a cardiomegaly or pulmonary edema. Let us see the gist of pathophysiology here. Whenever there is coarctation in preductal type, there is increase in the afterload. So this increase in the afterload and increase in the left ventricular pressure here. So because there is a backflow of this blood. So since there is also a patent ductus arteriosus, there is more amount of blood reaching the aorta from the pulmonary artery. So there is more backflow of the blood to the left ventricle. So there is volume overload, and there is also, because of this, there is backflow to the there is also pulmonary edema because of increase in the pulmonary blood flow. As soon as this patent ductus arteriosus closes, there is increase in the stress over the heart, because up till now patent ductus arteriosus is supplying the lower part of the body. So but here, as soon as this PDA, that is patent ductus arteriosus, closes, there is more stress over the heart for pumping to the lower body, to supply to the lower body to avoid the cyanosis of the lower body. So there is increase in the stress over the heart. So there is dilatation and also hypertrophy leading to cardiomegaly. That's why we will see pulmonary edema, and also pulmonary edema is because of the increase in the pulmonary blood flow, and also this cardiomegaly is because of the dilatation and hypertrophy. So the radiological signs are different. So whenever we see rib notching and figure of 3 sign, it's postductal type. Cardiomegaly and pulmonary edema is seen in preductal type. So this is a gist of coarctation of aorta, and these are the important points in the coarctation of aorta.